Okay, folks, stand by. In final, bear with us.
Good morning, everyone. Thank you so much for being with us today. I'm Dr. Joss Reimer, the medical lead on Manitoba's Vaccine Implementation Task Force. I am pleased today to be joined by Dr. Marcia Anderson. Dr. Anderson is a medical officer of health with Indigenous Services Canada and the medical lead of the First Nations Pandemic Response Team. As well, Dr. David Mateer, health system co-lead of the Unified Health Sector Incident Command, is here with us. Thank you to both of you for making time from your very busy schedules to bring some information to Manitobans today. Dr. Anderson will be presenting a data update on the vaccine program, specifically as it relates to people who are Black, Indigenous, or people of color. And Dr. Mateer will share some data and speak to some of the most pressing impacts of COVID-19 on our healthcare system. So first, we will start with Dr. Marcia Anderson.
Thank you, Dr. Reimer. As they bring up the slides, I'd just like to acknowledge as well Dr. Jill Warwick, who's the senior epidemiologist at Manitoba Health Seniors and Active Living, who leads all of the analysis by race, ethnicity, and Indigenous identity, as well as the race, ethnicity, Indigenous identity working and advisory group, who has been supporting this work since April of 2020 and contributes to the analysis and the recommendations. If we could go to the next slide, please. On January 31st, Dr. Warwick did an analysis of immunizations given by racial, ethnic, and Indigenous identity. On 139,649 people had received at least one dose of the vaccine and had their identity reported. Of those, 40.7% identify as a member of a BIPOC community. Of those who are fully vaccinated, almost 40% identify as member of BIPOC communities. If this was proportional to the population size alone, we would expect it to be about 36%. Of those who have received a third dose or a booster dose, 28% identify as a member of a BIPOC community. And of those who have received a first dose of the pediatric vaccine, 50.7% identify as members of BIPOC communities. Next slide, please. So this slide is showing the timeline of when those first doses were given. And we've included some of the key accessibility initiatives that were designed to be more responsive to the needs of diverse populations. So we can see that first black arrow corresponds to April 26, which is when the urban Indigenous clinics opened. The next one corresponds to May 3rd, which is when language services were added to the booking line as well as at the super sites. And on May 5th is when people aged 45 and up were eligible. That was a key landmark for members of BIPOC communities because 46 was the median age of hospitalization due to COVID. On May 11th is when paid leave for attendance at a vaccine appointment was introduced. And on June 3rd, community outreach grants were announced, which made it possible for community organizations, cultural centers, faith-based organizations to become part of the vaccine rollout by hosting clinics in spaces that were known and safe for members of diverse BIPOC communities. Next slide, please. This slide shows the timeline of dose 2, and it will become important later on when we talk about how vaccines impacted cases in BIPOC communities. And you can see there are two peaks in there. One corresponds to about June 24th, and the second peak corresponds to early August. Next slide, please. This is a population pyramid that shows the difference in age structures between members of BIPOC communities and people who identify as white. Now, I do want to note that although we have aggregated all BIPOC communities together, it's important that we keep in mind the diversity or heterogeneity that exists within these communities. We can lose some of this perspective when we aggregate them together for statistical purposes. What we notice is that 32% of BIPOC communities are under age 20, compared to 23.6% for those who identify as white. There's dramatic difference as well in the population, the older age groups of the population, with 15.6% of white people being over age 65, but only 5.3% of members of BIPOC communities. This age structure is important to keep in mind when we look at the next slide, which shows the age structure of people who've received the vaccine doses. If we can go to that slide, please. Oh, one slide back. Thank you. And so what we're looking at here is the red lines represent members of BIPOC communities, and the blue lines represent people who identify as white. And in younger age groups, we can see that BIPOC community members actually make up more of the doses given, whereas we get older, particularly over 40 to 49, 50 to 59 and up, dramatically more doses given to people who identify as white compared to people who identify as a member of a BIPOC community. And this in large part is due to the age structure that we showed on the previous slide. Next slide, please. Now, this also shows that dose 1 timeline, comparing the date of doses given for people who identify as white, that is the blue line, and people who identify as members of BIPOC communities, which is the red line. And so we can see that there is a delay in the time when members of BIPOC communities started getting vaccinated at high numbers compared to people who identify as white. This highlights the need for responsive planning in both eligibility criteria as well as service delivery in order to have those lines closer together earlier on. Next slide, please. This graph is showing numbers of breakthrough cases, so cases that occurred 14 days or more after a second dose is received. And again, the red bars represent members of BIPOC communities, and the blue bars represent people who identify as white. Now, since members of BIPOC communities make up about 36% of our population, all things being equal, we would anticipate that the red bars would be about 1/3 the height of the blue bars. And we can see that that's not the case. That actually, and particularly in the middle of the graph there, we can see the red bars were actually higher. This indicates that the risk of breakthrough cases is higher amongst members of BIPOC communities. Next slide, please. So just a few key messages from the COVID vaccine data. First of all, and as we've shown in the past, BIPOC community members are at higher risk for COVID-19, including severe outcomes due to COVID-19. We'd previously shown that the average age of people admitted to hospital was younger for BIPOC folks compared to people who identify as white. We've also shown here that the average age of BIPOC people who are vaccinated is 10 years younger, and that's true for all 3 doses of the vaccine. These communities are much more likely to be vaccinated in Winnipeg, so 75% of all doses were given in Winnipeg, compared to 56% for people who identify as white. And there does appear to be that lag in vaccine timing for all 3 doses of the vaccine. Lastly, we've noted that breakthrough infections are more common in BIPOC communities. We can go to the next slide. What we're going to start to look at is how these vaccines have shifted demographics over time amongst cases. And so in this graph, this orange area seen at the top represent the proportion of cases that are occurring in members of BIPOC communities, and the lighter yellow color represents proportion of cases occurring in people who identify as white. And we can see in the earlier part of the graph that disproportionately more cases are occurring in BIPOC communities, roughly 60 to 70%. Whereas in the later part of the graph, representing fall and into early 2022, that trend had changed with more cases occurring in people who identify as white. If we can go to the next slide, please. What this slide landmarks is how that shift really occurred following the administration of dose 2s to members of BIPOC communities. And so we can see landmarked there that June 24th or late June peak of second doses, and then a bit further on that early August peak. And after that, and through the fall wave, what we see is lower proportion of cases occurring among BIPOC communities. It's important we understand nothing else had changed. There is still systemic racism, there's still overcrowded housing, there's still higher rates of being in low income or higher risk occupations, and yet we've seen a dramatic difference in the proportion of cases occurring in these communities. Next slide, please. This was also reflected in the experience of severe outcomes. And at this point, I'd like to really highlight the remarkable success of BIPOC communities in supporting its members through outreach clinics, through communication and information sharing. I'd like to thank the members of mobile immunizations team who went out to these accessible clinics and all who contributed to the accessibility planning. It does also highlight how effective this vaccine was. And so in the fall wave, what we saw that 95% of folks who identify as BIPOC were never hospitalized, compared to 92.4% of people who identify as white. And on December 10th, that snapshot of a day when we looked at hospitalizations, 22% of people in the ICU and 25% of people in the hospital identified as a member of a BIPOC community. This is roughly or almost a third of the over 60% of people who identified as BIPOC in hospital in that earlier spring wave, as you can see noted on the bottom of this slide. If we go to the next slide, please. This is showing the same information, but it starts to include the data in January. And part of the concern, as we saw a shift to the Omicron variant, which we know had higher rates of breakthrough infections after second doses, we did start to see a shift with more cases occurring in BIPOC communities again. And we can see that this is also being reflected amongst those admitted to hospital. Next slide, please. This is also true for ICU, where we can see in the earlier part of the graph, more pink bars representing people who identify as white. And the later part of the graph gets more colorful again, with different colors representing different racial, ethnic, or Indigenous communities. That being said, we continue to see that this vaccine is highly effective. If we can go to the next slide, please. This next series of slides shows that vaccines remain highly effective at preventing hospitalizations, especially after the third dose, as Dr. Reimer and our colleagues have talked about being very important with the Omicron variant. But the next slide, please. The vaccines are preventing ICU admissions. Next slide, please. As well as deaths. The vaccines remain a critical tool in preventing severe outcomes amongst BIPOC communities. Next slide, please. So what we can take away from this is when there was both eligibility and accessibility, members of BIPOC communities made informed choices and got vaccinated. Since BIPOC people make up a higher proportion of those vaccinated than in the general population, this implies that uptake is actually higher among BIPOC communities than among those who identify as white. In the fall wave, this significantly shifted case and hospitalization demographics, with white people being overrepresented and BIPOC folks making up less than half the proportion of hospitalizations they did in the previous wave. And this is a remarkable public health success that occurred in collaboration with members, leaders of BIPOC communities. We are starting to see a shift again due to Omicron transmission dynamics. And again, this reinforces the need for us to apply the same accessibility lens to third doses, as well as to new treatments. With that, I'll thank you for listening, and I'll turn it back to Dr. Reimer.
Thank you so much, Dr. Anderson. Really dramatic data, and I really appreciate you taking the time to share it. Today, I would like to share some of the latest guidance from the National Advisory Committee on Immunization for vaccinating youth aged 12 to 17 against COVID-19 and its variants. This week, this past week, NACI announced its recommendation that youth aged 12 to 17 should receive a third dose of COVID-19 vaccine if they are at high risk of severe outcomes due to medical or social risk factors. So effective today, Manitoba is proceeding and following NACI's recommendation because we know that we have a significant population of teens who fit the criteria, who are at higher risk of severe outcomes and would benefit from being as protected as possible against this virus and its variants. So there are several factors that define who should get this booster. A complete list is available on the Protect MB website. So teens aged 12 to 17 are recommended to receive the third dose if they belong to a racialized or marginalized community that is disproportionately affected by COVID-19. And thank you to Dr. Anderson for going through some of the data related to that. Teens who live in shelters, group homes, or correctional facilities. And those teens who have underlying medical conditions, which put them at increased risk. The list of conditions that NACI pulled together is available on our website. I will note that there is no change to our recommendations for teens who are moderately or severely immunocompromised. These teens should still receive 3 doses for their primary series, with a 4th booster dose 6 months after they complete their primary series. NACI recommends an interval of at least 6 months between the 2nd and 3rd dose. That is because evidence in adults suggests that longer intervals bring about a stronger immune response. It is expected to be longer lasting and more effective, and may also be associated with a lower risk of myocarditis or pericarditis in teens and young adults. All along for youth, NACI and Public Health in Manitoba have recommended the use of Pfizer to minimize the risk associated with myocarditis and pericarditis. This inflammation of heart tissues is extremely rare, and it is mild to begin with when it occurs related to a vaccine. It almost always fully resolves without any severe long-term consequences. But when we have the options for which product to use, we want to use the one with the lowest possible risk of myocarditis. And in the case for teens, that means Pfizer. Parents of teens aged 12 to 17 often ask me about the safety and effectiveness of the vaccine and about the possibility of side effects. So with a third dose available for some teens, I'll review what we know today. When NACI assessed the need for the booster, they looked at the available evidence on the Omicron variant and the burden of COVID-19 disease in teens. They evaluated the risks associated with a third dose of mRNA COVID-19 vaccine in teens, including the rare risk of myocarditis and pericarditis. What we are learning from this is that prior to Omicron, vaccine effectiveness appeared to be high. It did decrease over time, however. Currently, data on the effectiveness and safety of a booster dose, specifically in the 12 to 17-year-old age group, is limited. Preliminary safety data from real-world use of boosters in teens has not shown any additional safety concerns. So while the data specific to how effective the booster is for this age group is still not fully available, we do know that it is safe. We also know from decades of experience with other vaccines and what we understand about how the immune system works, that there is no reason to expect there would be any long-term effects for this age group related to getting a vaccine. We also know that some populations are at an increased risk of exposure to the virus and or increased risk of severe COVID-19 outcomes due to underlying health conditions and social factors. And that's why, in addition to knowing the safety of the vaccine, we make this recommendation to protect those that we know are at higher risk. I want to be clear at this time, neither the province or NACI is recommending boosters for the general population of youth aged 12 to 17, only those who meet the criteria that I've highlighted. That is because most teens who have already received 2 vaccine doses are at very low risk of severe COVID-19 outcomes, and that includes related to the Omicron variant. While we have seen a decrease in protection against infection with Omicron, unlike what we saw in older adults, teens with 2 doses remain very well protected against hospitalization, ICU admission, and death. So for most teens, it is not yet clear that a 3rd dose provides a significant additional benefit. If your child doesn't fit into the eligibility categories that I outlined, but you still feel that they should be immunized, please discuss your individual circumstances with your family doctor or your pediatrician. I'd also today like to briefly touch on the topic of vaccine equity, in particular because of the great data that was just shared by Dr. Anderson, to highlight some of the things that Manitoba has done and will continue to do to ensure that everyone, regardless of their age, race, socioeconomic position, or where they live, has access to protection from COVID-19 through the vaccine. We have reached a time in the vaccine campaign where regional health authorities are being asked to focus even more priority attention on reaching Black, Indigenous, and people of color or BIPOC communities. And how this will happen will look different from region to region and from community to community. While province-wide, we have seen strong uptake with the 2nd dose, as Dr. Anderson just demonstrated, the same can't yet be said for the 3rd dose. So there is significant work still to do. Many people face barriers to receiving healthcare services in Manitoba. So we need to be creative and agile to find ways to reach people where they are at, working with community members who are experts in how to work with these communities. Over the past year, public health and our many community partners have been promoting and enabling fair access to health for communities disproportionately affected by COVID-19. A few examples of some things that we have done and are doing include visiting homeless shelters, running vaccine programs at the shelters, and operating mobile vaccine clinics in various neighborhoods around the province. We have Indigenous vaccine clinics being held at Indigenous community organizations, operating in-school and after-school vaccine programs in schools around the province. Vaccine information is being provided in multiple languages. And we've also partnered with cultural centers and community groups to run clinics specifically for their members. We've partnered with several disability organizations to enable accessible vaccine clinics for people with disabilities. And we've reached out to people who live in group homes who face barriers to getting out into the community and serve them right where they live. We even vaccinated people at shopping centers, campgrounds, and in public parks. There are still challenges in reaching everyone, and the work continues, but we are experiencing a significant success in this aspect of the vaccine campaign, and it's clearly saving lives. It's protecting Manitobans from severe outcomes, hospitalizations, and preventing infections. But I did want to make sure to let Manitobans know today that the regional health authorities are working hard to make 3rd doses just as accessible as previous doses have been. That brings me to my weekly reminder to Manitobans that if you have not received the next vaccine dose that you are eligible for, please make time to prioritize this healthcare aspect in your upcoming week. You know, today is even better than waiting till later in the week. Contact the provincial call center, visit the website, contact your local pharmacist, your healthcare provider, visit a pop-up in your community or an Indigenous vaccine clinic. The RBC Convention Center site in Winnipeg is accepting walk-ins again, so this is a great opportunity for everyone in the family to get up to date together. Another accessible option is to go to a school that is operating a vaccine clinic. Overall, hundreds of Manitoba schools are participating in the school program at different times, and adults are welcome to drop by after school hours in those schools running after hours clinics. I know that we all want this to be over. We are tired of the pandemic and its effect on our lives. I just want to thank every Manitoban once again for doing your part to protect yourself, your family, your community, and all of us. What you may not be able to see, but what we know to be true is that if you had not been vaccinated, if you didn't get your family members vaccinated, things could have been so much worse. It's difficult to be able to count up all of the cases, hospitalizations, and deaths that you have prevented. But the positive effects of your decision to get vaccinated are all around us. The actions that you take make a difference. And so we thank you for taking this step to make your lives healthier and to help protect all of us in making these positive healthcare choices. Before I hand over to Dr. Mateer, I just wanted to say that this week is Resident Doctors Appreciation Week in Manitoba. Resident doctors provide so much of the critical care that Manitobans need in hospitals and in our communities. And I know that a significant number of you have also been providing vaccines at our provincial sites, as well as in the clinics that you are training in. So thank you for all that you do for Manitobans, and specifically from me, thank you for your help in protecting Manitobans with this vaccine. So I'll now invite Dr. Mateer to bring his health system update, and right after his presentation, we will take your questions. Dr. Mateer.
Thank you, Dr. Reimer. Good morning, everyone. My name is David Mateer, and I'm the Incident Commander for Manitoba's response to COVID-19 during this wave. There were 702 COVID positive patients in hospital this morning, which is down 14 from yesterday. The good news is that these numbers have continued to plateau in recent days. In the past week, we've seen the number of COVID positive patients hospitalized decrease by 4.5%. To give some context, the number of COVID positive patients in hospital was increasing as much as 70 or 80% week over week in early to mid-January. So we're headed in the right direction. And while new COVID admissions to ICU are still higher than we'd like, these numbers are coming down from what we are seeing a week or two ago. We had 3 new COVID positive patients admitted to ICU yesterday, and we had 27 in the past week. As of midnight, there were 109 adult patients in ICU. This number includes patients receiving both COVID and non-COVID care. The number remains well above pre-pandemic levels and places a strain on our staff and on our hospitals. As a reminder, the pre-COVID baseline capacity for Manitoba's adult critical care program was 72 patients. Of the 109 patients in ICU this morning, 47 were COVID positive. There were also 2 COVID positive patients in our pediatric ICU. A few weeks ago, while Omicron was the dominant variant across much of Manitoba, a majority of COVID patients in our ICUs were still confirmed to have the Delta variant. In recent analysis, we're seeing that shift, with approximately 90% of ICU patients with COVID now confirmed to have Omicron. What this tells us is that while Omicron is showing less severe outcomes for most Manitobans, there are still those in our communities who are vulnerable to severe illness. While the situation is improving, we do continue to remind all Manitobans to get vaccinated, get your booster dose, stay at home when you're sick, and to make choices about activities and venues that you're returning to as restrictions begin to loosen. Vaccines are proving effective in protecting people from the most serious illnesses, but they're not a guarantee against contracting or spreading COVID. As we return to more normal activities, giving thought to our interactions is going to become a very normal part of our lives, just as screening for symptoms has become. Things in the healthcare system are showing signs of slowing, but don't misinterpret that for anything resembling normal. It's very busy. There are still many staff redeployed away from their normal duties to support the care of COVID patients. And there are many Manitobans who continue to wait for procedures. We are continuing to do the work we need to in order to provide Manitobans with the care they need. Our medical, operations, and planning leads continue to monitor the ICU and overall hospitalization trends very closely. And we have contingency plans in place ready to respond if needed. We're very much looking forward to having this wave in our rear view mirror, but we're not there yet, although we're headed in the right direction. For the past 2 years, we've been monitoring the number of COVID positive patients in hospital and using that data as a guide for planning and for measuring capacity. Now we're yet again in unknown territory as we see very high numbers of COVID positive patients in hospital who aren't necessarily there for treatment related to their COVID infection. With widespread transmission, many of the people who would be seeking care for accidents, trauma, emergency situations, labor, and so on, happen to be COVID positive. As an incident command, we've been looking at these numbers grow in both hospital units and ICU, and we've been working to better understand the proportion of patients who were admitted to hospital due to COVID and those who have the virus that are in hospital for other reasons. The work has involved a manual review of medical charts of COVID positive patients by information experts who've been tasked with looking for a number of criteria. The reason for doing this are twofold. One, the information supports our operational response to increased demand on the healthcare system. And two, it supports our planning efforts, which are so important to our ongoing response. We know testing and test positivity rates have become less reliable indicators of COVID's activity in our province due to changes in testing criteria. However, hospitals have continued to test every admitted patient, giving us a reliable sense of the proportion of patients with the virus and patients being treated for the virus. We released some preliminary data to media specific to Health Sciences Centre a few weeks ago, and today I can provide some updated numbers. As a reminder, this is not intended to be portrayed as an exact analysis. Rather, this is a broad overview compiled via patient chart information related to listed reasons for admission, as well as diagnosis and COVID status. This review included patients in medicine, critical care, mental health, child health, and women's health units. It excludes patients being seen in emergency departments who didn't require admission. Since January the 17th, this review has looked at patient charts of COVID positive patients in hospitals throughout the province. The review found about 65% of patients with COVID in ICU last week were receiving care directly related to the virus. This would include active and infectious patients experiencing severe respiratory symptoms or COVID pneumonia, but also include long-term COVID recovered patients who remain very sick. The remaining 35% were receiving care for other non-COVID conditions and illnesses, but also had COVID. These numbers have shifted over the past few weeks as the dominant strain has moved primarily from Delta to Omicron. 3 weeks ago, there was an 80-20 split, with 80% of COVID positive patients in ICU being there due to COVID. This information, combined with an ongoing analysis of vaccine status of each patient, is directly informing our understanding of the severity of the virus, particularly on the unvaccinated or partially vaccinated population. This shift is important. Over the past 2 weeks, we've seen some large numbers of COVID positive patients in our ICUs, including multiple days where 8 or 9 COVID positive patients were admitted to ICU. Despite these high numbers of admissions, the overall patient count in our ICUs over the past 2 weeks has remained elevated, but relatively consistent averaging 108 patients over the past 14 days. Across non-critical care units, we are seeing slightly different ratios, but trends in the same direction. We had an average of 66% of COVID positive and COVID recovered patients in Manitoba's hospitals last week who were receiving care for a reason other than their COVID infection. This could include car accidents, slips and falls, emergency surgery, and other traumatic events or conditions. The remaining 33% of COVID positive patients were being cared for in response to their COVID illness. These numbers have also shifted in the past 2 weeks, although to a smaller degree than in critical care. 3 weeks ago, we had roughly 40-60 split, with 40% of COVID positive patients in hospital due to the virus and 60% for another reason. So why is that important? The distinction won't change the overall capacity our hospitals have for treating inpatients. Sick and injured are still sick and injured, and these numbers don't change that. We estimate that there were 228 patients in Manitoba hospitals on Friday receiving treatment specifically related to their COVID infection. This is a significant and sustained impact on our health system and our healthcare providers. It similarly doesn't change how we treat or cohort patients or the personal protective equipment that staff are required to wear to keep them and others safe. What it does tell us is the impact of the virus on our capacity today. It also gives us something to measure against as vaccines continue to demonstrate their effectiveness, as COVID treatments are offered, and as outpatient therapies allow patients to recover at home. So while the ratio in hospital may be approximately 40 to 60 today, we expect to see that ratio continue to change as COVID illnesses begin to subside, as treatments are administered to those that are eligible, and as vaccine uptake rises. In the meantime, we continue to manage the system as we have throughout this Omicron wave. We continue to support staffing needs in the most impacted and urgent areas. Nearly 250 staff have been redeployed to support increased patient demand in ICU and medicine units. We've also deployed more than 170 staff to personal care homes. This includes certified and uncertified healthcare aides and nurses. We continue to recruit and train staff to support necessary and valued work in critical care units and personal care homes, with 30 nurses having started the 12-week critical care nursing orientation program today. And the uncertified healthcare aide micro-credential course offered by Red River College Polytechnic and Assiniboine College continues to produce staffing supports at personal care homes throughout the province. We also continue to make some necessary patient moves to ensure that Manitobans can access care in our most specialized healthcare facilities. The interregional transfer protocol has resulted in 270 stable patients being transferred to sites outside of their home health region in the past 3 months. This includes 13 in the past week. While we recognize the concerns of affected patients and their families about the distance from loved ones, we also appreciate their understanding that these transfers are necessary. We're also continuing to admit patients to the Virtual COVID Outpatient Program, or VCOP. This program continues to provide home care to patients with COVID to help those who may require home oxygen or other supports during their recovery. To date, the program has cared for nearly 500 patients, including 23 patients currently, and saved approximately 3,500 inpatient days in hospital. The VCOP gives patients a safe alternative that allows them to be cared for remotely at home while freeing up hospital and staffing resources to care for inpatients. To wrap up, the health system continues to respond to the unprecedented challenges that this pandemic and this current Omicron wave have presented. We continue to have the necessary capacity in place through a period of high patient demand and high staff sick rates. Our ICU capacity is at 124 beds, which is up 1 from last week. and we have contingency plans to expand further if needed. Our medicine bed capacity on Thursday night was at 1,574 beds, with 160 beds available for use. There is a cost to all of these efforts, though. Pulling staff to assist in various high-need areas like ICU impacts our capacity to provide other services, such as non-emergent surgeries. It also has a real impact to staff who have had to face this pandemic head-on for the last 2 years. Despite being very tired, they continue to do all they can to support their patients, providing care, patiently answering questions, showing compassion in others' time of need. We thank them for all they do for their patients, and we continue to encourage Manitobans to reduce the strain on our workforce by getting vaccinated and getting their third dose as soon as they are able to. Vaccines significantly reduce the risk that you'll end up in our hospitals, which will help our staff and allow our health system to more quickly return to normal operations. Thank you. And at this time, I think we'll open to questions.
Thank you, doctors. A reminder to our reporters on the line, you will have one preliminary and one follow-up question. We ask you to be brief today. Some of our physicians may not be able to remain much longer, but we'll start with from CJOB, Skylar.
Hi, doctors. Thanks for all the information and time this morning / afternoon. Dr. Mateer, I think I'll start with you. I asked Dr. Roosin this last week, but he thought, somebody like you might be better positioned to answer a question like this. You just gave us an update on the overall medicine bed capacity with, 160 or so beds available out of the 1,500-ish provincially. How much or how similar is that to the average flu season? And what context needs to be remembered during this time as well? You mentioned some of the healthcare worker burnout, delayed surgeries, and things like that. It's not apples to oranges, is it?
Well, first of all, probably I'm not the right person to be asking for a comparison with previous flu seasons. I think that's possibly more appropriate for a public health physician. But I can say that we're maximizing the capacity that we have within our healthcare system. So you mentioned those medicine beds. That's all important, and that's why we are using the inter-facility transfer protocol to maximize the acute care capacity that exists in medicine beds, so that therefore we can obviously admit patients who need to be hospitalized for COVID and non-COVID reasons, but also move patients more quickly out of ICU when they're ready for transfer and they no longer need that level of care. The other part of, I think your question was around the resilience of healthcare workers. And we're doing as a province, in combination with all of the SDOs, looking at resilience within the entire healthcare system, what we can do to support our healthcare workers through this wave and through COVID, from the start of COVID, and what measures we can take in terms of leadership of the healthcare system to ensure that we're supportive and that we provide all of the supports necessary for our healthcare workers to provide this ongoing care in such trying times. But I can tell you there's a couple of initiatives ongoing there. Hopefully that answers the questions that at least I'm qualified to answer. Thanks.
Yeah, I appreciate that. Thank you very much. Dr. Reimer, this one's for you. I know you mentioned last week or maybe the week before that, that if somebody had recovered from COVID-19 and they were looking for their next vaccine dose, whether it be, second or third, that they could go for that as soon as they are, starting to feel better and aren't at risk of infecting anyone else. But I did see since then that NACI has changed their recommendation and are asking people to wait 3 months again. Is that correct?
Yeah, NACI came out with new recommendations on Friday. So our clinical team is reviewing those recommendations this week to determine what we want to do here in Manitoba. And the NACI recommendations, they differ depending on if you're talking about first, second, or third doses, and depending on whether or not the individual is immunocompromised or not. So it's their advice is not as simple as just the 3 months. It's between 4 weeks up to 3 months, depending on the individual circumstance. But we will be looking at that here. It's a very challenging piece of advice to give because, as NACI noted, there's not a lot of evidence on this exact question that we can use right now. We will soon have evidence because so many people have experienced infections, but don't have a lot of specific evidence about COVID-19 infection and the impact of timing of the next dose to go on. So, for now, it's critical that Manitobans make sure they've recovered from their infection before they come to any clinic for an additional dose. That's both for their own benefit, as well as to help reduce the chance that they could spread the virus to anybody at those clinics. But beyond that, we'll need some time to review the NACI recommendations before we come up with our own.
Thank you.
From the Winnipeg Sun, Glenn.
Sorry, it took me a while to get off mute. Yes, this is for Dr. Reimer. Just for a little bit of clarification, the NACI recommendation on, I guess, use on getting their third dose, those without compromised immune systems were not, or the recommendation was not for them to get their, or they were not changing the recommendation on third doses for them. Any indication when that group might be eligible for third dose, or is that something that is not being contemplated?
Yes, thanks for that question. It's a great chance to clarify. For youth who are immunocompromised, we had already recommended that they get 3 doses as their primary series and a booster dose, which for them is a 4th dose 6 months after they finish their initial series, which for them is 3 doses. So what I was saying is that there's no change to that recommendation. Rather, there's now additional groups in that age group that also can receive a booster dose, which for most of them would be a 3rd dose. So for people who have the health conditions, things like active cancer treatment, chronic kidney disease, pregnancy, for anyone who is part of a racialized or marginalized community affected by COVID-19 disproportionately, or those youth living in congregate settings, they now also can get that booster dose in addition to the immunocompromised youth who are already eligible.
So if I understand, I thought you had also mentioned about those within that age group without those underlying conditions, or perhaps I misunderstood what you said earlier about that. I'm wondering if you can clarify. I'm talking about those people, those within that group without those compromised systems.
Yeah, so for youth who don't fit into any of those categories, there's no recommendation from NACI nor from Manitoba for them to receive a booster dose. So we're not recommending a booster dose for low risk youth age 12 to 17 at this time. And I don't have any estimate about when or if that might change. Right now, it looks like those low risk youth are well protected against severe outcomes. And continue to be well protected. So the only time that recommendation would change is if there's evidence showing that booster dose is important for that age group to reduce the risk of severe disease for them.
From CBC Radio Canada, Emil.
Hi there. I guess my question would be for Dr. Meteor. As the number of hospitalizations seems to be at least plateauing, what would be your criteria to start considering putting ICU staff back in other services or restarting non-urgent surgeries?
Thanks for that really important question. And we're already planning for that. So as we're, for example, for ICU beds, we plan for any eventualities. When the incident command, we're planning for an increase in ICU, for example, in the number of beds, and looking at the criteria by which we would do that and the timing. So at the same time, we would be planning for what would it take and what would be the triggers and the criteria for reducing the number of beds, and then as a result of that, redeploying staff returning staff back to their operational role. So those are ongoing, and it's just part of the planning process. So at this point in time, I can't run through the criteria that we have in place right now, but I can say that those criteria are being identified in order that we can return to a more operational state as quickly as we possibly can, without risking any upturn in any of the numbers that we're seeing, whether that's in hospital acute care beds or in ICU. So we have to plan for that variation. For example, the number of patients that may be admitted to an ICU in a particular day. So the trend's all important, but we have to also plan to make sure that we have capacity for that variation as we start to return to a more normal and operational state.
All right, thank you for that. And also you spoke about virtual care for COVID patients. Are you considering expanding that program to relieve the pressure on the system?
Yeah, with the VCOP program, anybody who can be safely cared for and supported in home with home oxygen and other supports, they would be eligible for that program, and we're looking at that actively. Ideally, we would like to increase the numbers there, yes. Anything that is appropriate and safe that can maintain capacity in the acute care system to care for patients who require acute care or more intensive care, as we've talked about. That's what we're trying to do there. And yes, we are using that to the maximum capacity currently. Thank you.
From CBC Manitoba, Bart.
Hey there, Dr. Mateer. In terms of the analysis of COVID patients versus COVID patients that are not getting COVID treatment, some doctors have pushed back against that sort of analysis, noting that just looking at respiratory treatment isn't looking at the whole picture, given the fact that COVID causes systemic effects that can weaken somebody for other areas such as heart conditions or kidney conditions or whatnot. What would you say to the criticism that this analysis is flawed to that extent?
Well, this analysis is just a tool, really, in terms of operations and planning. So it gives us a sense of the number of patients, the proportions of the patients with COVID that are being treated for COVID and without COVID. And we get a sense then of the trajectory of the challenge that we're facing, of the impact on our healthcare system. So I'm not really I'm using it as a tool to be able to move through the operational steps we need to and the planning steps in order to be able to return, hopefully, to normal operations as quickly as possible. I can't really comment on the medical aspects of it, but it certainly is a planning tool that's helpful for us to understand.
Okay, but why would that be helpful if COVID, long COVID, is causing all kinds of heart conditions and other systemic effects? How helpful is that really?
But it is helpful in terms of, how many patients are we seeing? We're seeing a trend with those that are being treated for COVID directly in the healthcare system. And if that's decreasing, in all likelihood, we're going to see a reduction of the impact of COVID on our healthcare system operations, because those people who are in for other reasons would be in for those other reasons in the healthcare system and have treatment anyway. They just happen to have COVID. So it gives us a sense of the trajectory of COVID and the impact on our healthcare system.
It doesn't sound like you heard what I was saying with either questions there. I was saying, what about people that COVID causes other conditions that are, if COVID causes somebody to exacerbate somebody's heart or kidney conditions or diabetes, if it weakens them so that other chronic conditions put them in hospital, is that not a COVID patient?
Well, yeah, I know what you're getting at now. And of course, every patient that comes into the healthcare system is assessed clinically and care is provided to meet the needs, whether that's directly COVID related or not. And so I can't really comment on medical diagnoses or medical treatments, but I can say that everyone that comes into the healthcare system will be appropriately treated to meet their needs.
From the Canadian Press, Steve.
Oh, hi, Dr. Mateer. Can you tell us what the status is in terms of the number of people each week that are being transferred within the province, but outside their region to free up beds? Has that plateaued or changed in any way?
Thanks for that. I think there were 270 over the last 3 months, and it's not really a numbers exercise, but it's more appropriate care. So if we have patients who are in acute care facilities who don't require an acute care bed, don't require to be cared for in a hospital environment, then those patients would be identified as potentially being moved from acute care then to a more appropriate environment to receive their care. So it's about the appropriateness of care. And while those numbers are still growing because we're identifying people on an ongoing basis that perhaps don't require acute care, it's not really about the numbers. It's more about where those patients would receive the most appropriate care in the healthcare system. So it will be an ongoing activity.
But my understanding is that these numbers are much higher than normal. While it's always happened to have these sorts of transfers, it's much higher because of the stress on the healthcare system during this current wave of the pandemic. Do you foresee a time when it returns to normal levels?
Well, it depends on what normal should be and what it was. So within the healthcare system currently, yes, we have an intentional strategy of maximizing the capacity in the acute care system to be able to care for people who require acute care, moving patients out of acute care that don't require that care. Previously, perhaps there wasn't such an intentional focus on that. And maybe we ought to, in terms of being able to operate the healthcare system as efficiently as possible, look at how we can maintain that kind of approach, while of course recognizing it's not, not a numbers approach. It's not a numbers exercise, but it's looking for appropriate environments so that patients can have their care needs met in the appropriate area in the healthcare system, not necessarily to do with acute care only. So it is about operational effectiveness and efficiency, but also a kind of overriding, really, for me, is about where that patient ought to be cared for in order to have their care needs met the most appropriately in the care system that we have.
From the Winnipeg Free Press, Katie.
Good afternoon. I have a question for Dr. Anderson. With the race-based data that you released today, how has that data been used to shape Manitoba's vaccine rollout, specifically the rollout of the third doses?
Thank you for that question. And I'll just highlight a couple of the things that Dr. Reimer shared earlier, which is to renew the focus on the accessibility plans to increase booster dose coverage. And so perhaps returning to some of those community centers, cultural centers, faith-based organizations, the sites that worked before will be done again. So again, renewing that focus on accessibility was one. The second was when we examined our data, it clearly showed that there was higher risk of COVID-19 amongst racialized communities. This includes Black communities, Indigenous communities, other racialized communities. And so adopting that NACI recommendation that those 12 and up who are members of racialized or marginalized communities also now eligible for boosters 6 months after their second dose. Dr. Reimer, was there anything additional you wanted to highlight?
Yeah, thanks for that question. I would say that many of the accessibility things that we did the first time we saw data like this in the spring, we've continued to do throughout the rollout, but there are certainly things that we can still enhance. And so it's going to look different from community to community because we know that meeting the needs of individual communities requires individual assessment and following the advice of community experts. So it's not one process that we're using for the whole province. We do want to partner with members of the community to make sure that we are meeting their needs in a localized way.
Thank you. And we've seen the hospitalization rates for members of BIPOC communities. Have you been able to determine the impact of the patient transfer protocol, for example, or the surgery and diagnostic wait list on those communities as well?
No, we don't have the information to examine what the patient transport protocols, how that may have impacted BIPOC communities at the population level, or the surgical or diagnostic backlogs. I'm not sure if we would have the capacity from a system level to do that at this point, but that's certainly something we can take away and look into further.
From CTV Winnipeg, Michelle.
Dr. Mateer, I wanted to circle back on, you said be cautious as restrictions are lifted, giving thought to your interactions as a part of life now. What do you mean by that? Like, as restrictions lift, what situations should people be, you know, kind of thinking twice about? Just expand.
It's just really based on the principle that even with a vaccination, it doesn't guarantee that you're not going to contract or transmit the virus. So in order that we can minimize the risk to the entire community, to follow ongoing public health guidance, really, around some of the safeguards that we can adopt in order to be able to limit the transmission in the community. So that's really what I was driving at there.
What about as we loosen restrictions for people who are immunocompromised? What has been taken into account for people who are still at high risk, even though the circulation in the community might not be as high?
Probably not a question for me, more for, I don't know if Dr. Reimer would like to answer that or.
Sure, I know that this question was asked of Dr. Roussin last week as well. And you know, we take very seriously the risk to people who have underlying health conditions, those who are immunocompromised, because it is clear that we've seen that harms can be greater when you have those risk factors. And that will remain true for COVID. It's true for other respiratory viruses. Individuals who have these health concerns have to always be cautious and consider what exposures may put them at highest risk. So, you know, as we make these decisions, as Dr. Roussin changes approaches to public health orders, that has to be carefully considered, and weighing out, you know, what impact this has on all of Manitobans, the impact it has on mental health, the impact it has on youth, and trying to make the best decision possible for the province as a whole, knowing that every decision is going to have some benefits and some harms, but trying to very carefully balance those.
From Global News, Marnie.
Good afternoon. Dr. Anderson, this question's for you. Just based off the update last week, showing that First Nations hospitalizations were quite high in the month of January. And we know that Omicron kind of became more prevalent in some communities later than other parts of the province. So there's a bit of a lag there. How concerned are you about these numbers if they continue to rise in First Nations communities, particularly the remote ones?
I'm very concerned with the transition that we've seen with higher proportions, not just of hospitalizations, but particularly ICU admissions. And noting what Dr. Mateer had said, that a higher proportion of the ICU admissions actually due to COVID as opposed to incidental COVID. And I mentioned that because that's where booster doses would be really helpful, as well as equitable access to the evolving treatments, including both the oral antivirals and the monoclonal antibodies. So we are certainly strongly encouraging booster doses and would really like to see booster uptake higher in First Nation communities, as well as working with our health system partners to ensure that every First Nations person who has COVID symptoms, who might be eligible for monoclonal antibodies or oral antivirals, has equitable access and has the right information that they need in order to access that treatment. Between these two factors, really hoping to see that that proportion of ICU admissions occurring among First Nations people come back down.
Thank you for that. And Dr. Reimer, what has second dose uptake been like for the 5 to 11 age category, since more in that category are now eligible?
Yeah, we're just at the beginning of second doses being available for that age group. So we're definitely seeing many kids coming in. I think there's also been a number of infections that have occurred in this age group, which is going to be impacting the timing of dose 2 for some individuals. So I don't have that number in front of me right now, but in the coming week or two, we'll have a better idea of how many kids are coming in for that second dose.
From the Brandon Sun, Karen.
Good afternoon, everyone. Thank you for taking our questions. I just wanted to know, taking a look at BIPOC numbers, was there any particular reason why we were speaking to their numbers today? Because I've been tracking for a while, and we understood that there were an awful lot of challenges. So is this the government saying that you are increasing your efforts to try and reach out to them?
Thank you. So we have been monitoring the data along the way. It does take quite a lot of work to provide this level of detailed analysis, which is why we've only been able to do it periodically. When I started talking about this data with Dr. Reimer, Dr. Roussin, and others, we did start preparing for the data release. With the new NACI recommendation that came out for the boosters aged 12 and up, we knew it was pressing to be able to share the data to help members of BIPOC communities, families with young people in them, make informed choices. And so that was why we worked towards the data release today. Maybe I'll just, again, provide the opportunity for Dr. Reimer in case there was anything additional she wanted to add.
Yeah, I think the most important thing was the timeliness of having the data available to Manitobans. As Dr. Anderson said, there's a lot of work that goes into pulling and analyzing and ensuring that we have an accurate representation of what they're experiencing. But there was no delay or strategic timing in the release. It's more about making sure that we have an analysis that is accurate to what's going on in Manitoba, and that we have a mechanism to communicate that in a meaningful way. So, I'm thankful to have that data available as we get to talk about these new NACI guidelines for youth age 12 to 17, because it really does reinforce why that group was included. So I really appreciate Dr. Anderson taking the time to share that today, because it does help us to communicate better with parents about why some groups are recommended to get the vaccine while others may not be.
Okay, thanks for that. And no follow-up for me. Both the questions that I had in mind have already been answered.
Thank you, everyone. Unfortunately, we have to conclude this session right now. Thank you to the doctors. And this concludes our media briefing.